Welcome to the Trinity Health IHA Medical Group Wednesday Wellness Series. This webinar is presented in honor of Men's Health Month and is titled Prostate Cancer Awareness. The presenting provider is Trinity Health IHA Medical Group Urologist Eduardo Kleer. Dr. Kleer sees patients at our Ann Arbor location. Welcome, Dr. Kleer.
Well, thanks, Allison. It's a pleasure to be here with you tonight, and I look forward to giving a broad range talk about the latest on prostate cancer, and I look forward to hopefully teaching some facts about prostate cancer. We'll go over potential risk factors for prostate cancer. What can you do to lower your risk? How is it checked, and how is it checked for? How is it diagnosed, and what are the various treatment options, including the latest options? So let's get started, and I look forward to answering questions at the end of the talk. So let's talk about risk factors for prostate cancer. Everyone talks. A very common question that I get when I see patients is, what about my diet? What foods are bad for increasing the risk for prostate cancer? What are good foods to eat to lower the risk of prostate cancer? Or if I have prostate cancer, what should I be eating to make it less aggressive? So let's start with the bad. Fried foods are just generally bad for your health, not only for heart disease, but also for cancer risk, including prostate cancer. Other notable foods that are bad for prostate cancer, especially if you have it, would be drinking whole milk because of the fat content. Donuts are also particularly bad for prostate cancer. So if you enjoy your Dunkin' Donuts in the morning, maybe switch to a healthier alternative. What are good foods if you have prostate cancer or to lower the risk for prostate cancer? A diet high in tomatoes or lycopenes. So anything with tomatoes, tomato sauce, tomato paste, tomato juice, tomato and tomato sauce on pizza, any type of fresh tomatoes or canned tomatoes, they're generally good for prostate cancer. Other foods that are good are soy, especially in the form of either edamame beans or tofu. That is good for prostate cancer. Green tea is also associated with a beneficial effect for if you have prostate cancer or lowering the risk of prostate cancer. And just, overall, the main thing is eating a healthy diet. A lot of, and you hear about this all the time, fruits and vegetables, low fat, limit meat. But particularly for prostate cancer are the ones that I mentioned, and just, eat a healthy diet. Certainly exercising is always good for your overall health. It does lower the risk for malignancy, including prostate cancer. Since obesity is a risk factor for prostate cancer, especially more aggressive type of prostate cancer. Try and stay fit. Also, as we get older, the risk for prostate cancer increases. We really don't know exactly why men who get older have a higher risk for prostate cancer, and I'll go over some figures shortly. Risk factors for prostate cancer, certainly having a family history of prostate cancer increases your risk. Now we can do genetic testing. So if you have a family member that had especially aggressive prostate cancer, you can get checked for genes that put you at higher risk for prostate cancer. The most common one is the BRCA or BRCA mutation. There's BRCA1, BRCA2. BRCA1, if you have that, you have about a 10% risk that you may get prostate cancer. If you have the BRCA2 mutation, you have a 15% risk of getting prostate cancer. The BRCA2 is more aggressive a more aggressive risk factor than the BRCA1 because it tends to affect men at a younger age, and it tends to be more aggressive prostate cancer. Also, if your mother had breast cancer and your father had prostate cancer, that puts you at even higher risk. So, or if your wife has breast cancer, that may have if you have a daughter, of course, she may be at higher risk for breast cancer. But if you have a son, even if you don't have a history of prostate cancer, but your wife has a history of breast cancer, she may pass on either the BRCA1 or BRCA2 gene, which does increase the risk for a male for prostate cancer. Other risk factors for prostate cancer that I did not list is environmental factors. So interestingly, if you live in Asia, for example, Japan, China, there's a lower risk of getting prostate cancer than if you live in a Western country like the United States. But if you take those individuals who move to the United States, they eventually develop the same risk for getting prostate cancer. The risk goes up more to the general population than if they had stayed, than if they had not moved. So that suggests that there are also some environmental factors as well as potential, dietary factors that we discussed earlier, when Asians move to the United States, they adopt a Western diet. So that's an interesting finding. Also, I didn't list it here, but also the latitude. If you live, for example, in Scandinavia, you have a higher risk for prostate cancer than if you live more in equatorial countries. And so it appears that this getting some sun, even though of course it also has risk factors as well for skin cancer, but vitamin D appears to have some protective effect for the development of prostate cancer. Next slide, please. So African-American men do have a higher risk of getting prostate cancer compared to Caucasians in the general population. And 1 in 5 African-American male will get prostate cancer, 20%, and 1 in 20 will die of prostate cancer. On the other hand, in the general population, 1 in 6 men will be diagnosed with prostate cancer in their lifetime, and 1 in 33 will die of prostate cancer. So unfortunately, African-American men appear to have a more aggressive type of prostate cancer, and that can result in a higher risk of dying from prostate cancer. Next slide, please. So how do we check or screen for prostate cancer? So the early prostate cancer, which is when you want to catch it, has no symptoms. So usually when men start getting urination symptoms, it tends to be because their prostate starts to enlarge. As we get older, the prostate enlarges and it causes men to complain of urination issues. The stream may get slower. They have to urinate more frequently. They have to get out more frequently at night to urinate. And I see a lot of men that are concerned that could suggest prostate cancer, but that is very rarely a sign of prostate cancer. That's a sign of just an enlarging prostate, which is completely independent of getting of prostate cancer risks. So we check for prostate cancer. The main way that we have is through PSA, or prostate-specific antigen, which is a protein that's secreted out of the prostate that gets into the bloodstream. And when there are issues going on in the prostate, for example, the prostate enlarges or it has an infection or it has cancer, the PSA levels get secreted into the bloodstream and get higher, which allow us to check your PSA levels. When is a good time to start getting checked for prostate cancer? What ages? So if you have a family history of prostate cancer, or you're an African-American male, you should start getting checked once you're in your early to mid 40s. If it's very low, then you can maybe wait a few years until you get it checked again. And by low, I mean less than 0.5. If it's more than 0.5, you should continue to get it checked on a yearly basis if you're at high risk. The general population should start getting checked with a PSA in their early 50s. So those are the best ages. So in your 40s, if you have a family history of prostate cancer or you're an African-American male, the rest of the population in their early 50s. Also, the other test that should be done is a digital rectal examination. It's obviously a test that most men avoid or don't want to get. And often a lot of primary care doctors don't offer it either. And unfortunately, I mean, it's not common that you're going to find prostate cancer on a digital rectal exam, but often we do. And if we feel a nodule, that can suggest prostate cancer. Other factors can cause nodules in the prostate, such as having a calcification in the prostate, or having abnormal non-cancerous growth in the prostate called benign prostatic hyperplastic nodules. But certainly, if you feel a hard nodule in the prostate, that can suggest prostate cancer. And there's some cancers, paradoxically, the more aggressive ones, that because they're so abnormal, they actually don't cause a very high PSA reading and have low PSAs, but you may be able to feel them on rectal exam. So we are often asked, do you really need to do a rectal exam every year along with a PSA? And my answer is, as long as you've had a rectal exam along with your PSA as a baseline, if your PSA is staying stable, you don't necessarily need to repeat that rectal exam. On the other hand, if the PSA goes up the next time you have it checked, then you should get another rectal exam. So if the PSA is stable, you don't necessarily need another rectal exam. But if the PSA starts to go up at your annual physical, then you should repeat another rectal exam. Often when you go get a colonoscopy, the gastroenterologist also will do a rectal exam. So you may want to ask them and make sure that they didn't feel anything abnormal. We often get referred patients from the gastroenterologist because they felt abnormal rectal exams at the time of colonoscopy. Next slide, please. So unfortunately, PSA has gotten a bad rap. And a lot of doctors actually, they still to this day don't even check PSAs, which I think is a bad mistake. We do know now what can cause false elevations about PSA. PSA is actually the best biological marker in all of cancer for detecting cancer, in this case, PSA. You don't have a better blood marker for checking any type of cancer or more specific prostate cancer, a more specific tumor marker than PSA in all of biology. The problem is that there are false reasons that one can check a PSA, which can lead to unnecessary testing, but we're not much more understanding. So often, the first time you may get a high PSA reading, it's always good to repeat it. Once you're aware of certain factors that can falsely elevate it. What are those factors? Practically speaking, for example, if you have a urinary tract infection, so don't get a PSA checked if you have an infection in the urine or if you have what's called prostatitis. If you are a serious bike rider where you're putting thousands of miles on your bike a year, that can sometimes cause the PSA to go up. Also, sexual activity within 3 days can falsely elevate the PSA. A lot of men are not told that you should not be sexually active within 3 days of having your PSA checked. So make sure that's not a cause for a false reading. If you're having problems emptying your bladder and you're not emptying your bladder well, that can also cause a false elevation in the PSA. So if you're having problems emptying your bladder, or you're not, you're having problems urinating, be aware that if you have a PSA checked, that can be a false reading. So make sure that you do something to empty out your bladder so that then you can repeat the PSA once your bladder is emptying better. Also, just as the prostate gets bigger, the PSA the PSA will go up as well. So, for example, I have some men that have very large prostates, 2 or 3 times the size of a normal prostate. So when they come in, they have naturally a high PSA, and they're concerned that they may have prostate cancer. And that's why, for example, we'll do a rectal exam to see how big the prostate is, so that at least we can reassure the patient it could be just because you have a large prostate. We'll do further testing. We'll talk about that. But so a large prostate can cause a high PSA reading, for example, a normal PSA tends to be less than 4, but some men have a normal PSA of 8 or 10. That's their baseline, just because they have a very large prostate. And generally, the PSA should not be much more than about a tenth of the size of the prostate. And we can measure the size of the prostate. So if your prostate size measures to be, for example, 40 cubic centimeters, then that means that if you have a PSA of 4, which is the standard high reading for PSA, 4 or higher, that actually may be a normal PSA for you, because your prostate size is 40 cubic centimeters, and a tenth of that would be 4.0. So again, you want to take into account what is the size of the prostate when you look at a PSA reading. Also, as we get older, so for example, a PSA of 4 in someone who's 50 tends to be high, but in someone who's 70, a PSA of 4 is actually not abnormal, and that's called age-specific PSA. So there's a lot of factors that we take into account when we see someone with a high PSA. Primary care physicians are not as aware about these different factors as us urologists are. So if you find that you have a high PSA, it's important to consult a urologist just to look into it further, because we don't want you to be concerned or nervous, even though it may just be a baseline reading for you. So don't be necessarily nervous that you could have prostate cancer. There are many reasons why your PSA may be elevated for non-cancerous reasons. Next slide, please. So how do we diagnose prostate cancer? What are the steps? Say we see a gentleman with a high PSA, and we think that, yes, it is a real finding. What is the best test to check? Nowadays, the best test that we use for checking abnormalities within the prostate is a prostate MRI. Many of you may have had MRIs of your back, of your muscles, and your hips or legs or arms, but we use MRI to check the prostate as well. It's the best test we have right now for looking in the prostate. We used to just use transrectal ultrasound, which can be used if you don't have good MRI facilities, but a prostate MRI has taken over the way that we diagnose prostate cancer. And if we see abnormalities there, then we can actually, we can do what's called fusion biopsies, where we fuse the image of the MRI onto an ultrasound screen, so we can use the ultrasound to help us guide the biopsy using the information on the MRI. Why can't we do the biopsy on the MRI? Because the MRI is sensitive to metal. They'll ask you if you have any metal in your body, you can't do an MRI. And obviously, when we're doing biopsies, we're using metallic needles. So that's why we can't do the biopsies through the MRI machine. But so a trick that we use is we can take the image on the MRI, fuse it onto our ultrasound machine, and that way we get the best of both worlds. We're using the ultrasound image where we see the MRI, and we can transpose it so that we can be using the information that we get on the MRI. We can see subtle findings that we don't pick up on the ultrasound to get to precisely target where we want to do the biopsies. Now, traditionally, the biopsies, when we do prostate biopsies, has been done through the rectum, what are called transrectal biopsies. And that's another reason why a lot of primary care doctors didn't want to necessarily offer PSA screening, because of the risk of getting a bad infection, sepsis, potentially life-threatening infection that will land you in an intensive care unit. and because you're going through the rectum. And the rate of that now is exceedingly rare because we've learned how to give appropriate antibiotics to minimize that risk. But right now that risk is about 0.5%. However, we can take it down to very close to zero using a new approach that we use, which is the transperineal approach, which is the technique that I use, which basically, instead of the needle going through the rectum, the needle goes through the perineum, which is the area between the scrotum and the anus. So you go through the skin. You're still using the transrectal ultrasound to visualize the prostate, but the needle, using special needles and guides that we use, instead goes through the skin instead of through the rectum, and that avoids the bacteria in the rectum, which results in virtually no risk of infection. And actually, when I do a transperineal biopsy, I don't even use antibiotics. And when one uses transrectal biopsies, you use antibiotics. The more antibiotics one uses, the higher rate of resistance that one can get to antibiotics. So, has become a problem. So transperineal, I think, is an excellent way, which avoids not only the risk of infection, but also the use of antibiotics. That is starting to become the preferred method of doing prostate biopsies. Next slide, please. So, of course, and a lot of men have been afraid or hesitant to get checked for prostate cancer because it's common that they've heard about possible side effects when one treats with prostate cancer. And traditionally, those have been problems with urinary leakage or urinary incontinence and sexual dysfunction. But now, using more advanced, surgical techniques or radiation techniques and other methods of treatment, which I'll talk about, those risks are becoming less common. And if they do occur, we have very good ways of treating them. So that should not make you hesitant to get checked for prostate cancer, because prostate cancer is actually the number 2 killing cancer in men behind lung cancer. So it's not something that should be that you should be hoping that you don't have because you're not getting checked for it. It's something that I think you should face, and there's very good treatments that may still not affect your ability to control your urine, or that could affect sexual function. So if you're diagnosed with prostate cancer, it doesn't necessarily mean that we're going to treat you aggressively. Now we have learned that a lot of prostate cancers, known as Gleason 6 prostate cancer, also known as group grade 1 prostate cancers, often grow very slowly. They're what we call indolent cancers, and they're cancers that you're going to die with, just like you may die with high blood pressure, you may die with high cholesterol, you may die with diabetes, you may die with it, but you're not going to die from it. So we've learned how to pick out these types of slow-growing prostate cancers, and when we find them, we can often do what's called active surveillance, which means we'll monitor you with a PSA, we'll monitor you with MRIs, we'll do biopsies every year or two, and depending on how the PSA changes, often the PSA may not change very much, and that will avoid the potential risks or side effects that result in treatment, often with surgery and radiation, which can cause those unwanted side effects that can affect the quality of life. So that's called active surveillance. And often in older men who may have significant other medical issues. For example, they do have a very bad heart disease, or they've had significant strokes, and may or have severe arteriosclerosis. Those are men that may die with prostate cancer rather than from it as well. And in those men, we do what we call watchful waiting, which that's more for older men rather than active surveillance, where we actively biopsy the prostate. Watchful waiting implies just doing more monitoring the PSA, and once it gets to very high levels, then taking action at that point in time. So that's the difference between active surveillance and watchful waiting. Now, established treatments for prostate cancer have traditionally involved surgery, and the most common surgery that we do is the robotic radical prostatectomy, which again can result in the risk factors for incontinence and sexual dysfunction, which I'm not going to get into very much this talk. But there's surgery, there's radiation therapy, which both treatments are pretty similar to each other in terms of their effectiveness. Radiation may have secondary effects in terms of frequent urination, may cause some radiation side effects such as bleeding in the urine and from the rectum down the road, although those risks are low. And some patients who are not surgical candidates benefit from radiation, and some patients don't want surgery, and they're both pretty equivalent, although it depends the aggressiveness of the cancer and at what age you're diagnosed with your cancer. Hormone therapy, prostate cancer needs the male hormone testosterone to grow. So if you shut down the food that makes the prostate cancer grow, which is testosterone, you will cause the cancer to regress. And that's a common treatment that we use, especially when men have prostate cancer that has spread beyond the confines of the prostate. We'll use hormonal therapy. That the side effects tend to consist of hot flashes and sweats, and that will lower your energy, sexual dysfunction as well. And sometimes you can do what's called intermittent hormonal therapy, where you just follow the PSA, and once the PSA goes down, you can stop hormonal therapy and then just monitor the PSA until the PSA goes way up, and then you can get treated again. And that obviates the side effects from continuous hormonal therapy. Now, next slide, please. So we've learned a lot actually in the treatment for breast cancer, because in women in the old days, they would have a whole breast removed, a total mastectomy. But in women, they use what's called a lumpectomy, where they just remove the cancerous part of the breast, and that way they avoid removing the whole breast. And so what have we learned that in prostate cancer? Unfortunately, when we do surgery for the prostate, we just can't take out the cancerous portion of the prostate, just because of the way that the prostate is constructed in our bodies. We can't just go in and take out part of the prostate. But we've come up with novel ways of just treating that part of the prostate that has the cancer, and therefore that avoids treating the whole prostate, which can lead to those side effects that we talked about, such as urinary incontinence and sexual dysfunction. And I'll show you just some slides of how these treatments work. The most common types of focal therapies that are available right now are HIFU, which stands for high intensity focused ultrasound. There's cryosurgery, or freezing the prostate. There's electroporation, which is a way which uses basically electrical leads that you can put into the prostate, and literally you run an electrical current. You put these electrical probes around the periphery of the cancer, and then you send electrical current between these probes surrounding the prostate, and basically it affects the membranes that protect the integrity of the cell in the cancer cells, and basically disrupts the cells, and they basically die that way through electrical current running through the prostate in the area where the cancer is located. So that's also a new treatment. There's interstitial laser, where you can put laser fibers into the cancer and kill the cancer that way. And there's also TULSA, or transurethral laser ablation of the prostate, which uses ultrasound focused energy inside a prostate MRI machine to kill the cancer from the inside out. The ones that I'm going to focus more on that are more commonplace are the HIFU, cryosurgery, and electroporation. Next slide, please. So again, not everyone is a candidate for these. Only if you have cancer in a certain part of your prostate, if it's not throughout the prostate, and if it's not a very aggressive type of prostate cancer. So HIFU stands for high intensity focused ultrasound. And the principle is just like, for example, if you take a magnifying glass and you take it outside underneath the rays of the sun, and you focus it, for example, on a leaf or a bug, you can set that leaf on fire as you focus the sun's rays to a focal point. And that's the same principle that HIFU uses. What we do is we have a transducer that creates ultrasound in a transrectal probe, and there are prisms in this ultrasound probe that can focus the energy of this ultrasound onto specific points in the prostate and create very high heat in focal points on the prostate and literally kill the cancer cells due to the high heat that can be emitted. And we can use it to, if you have a focal cancer in just certain parts of the prostate, you can very effectively use HIFU to just kill that part of the cancer, or sort of kill that part of the prostate that bears the cancer and leave the rest of the prostate intact, and therefore avoiding injury to the nerves and sphincter muscles that control urination and sexual function. Next slide, please. The next one that I'd like to just briefly mention is focal cryotherapy, where you can actually put freezing probes into the prostate through the perineum, the area between the anus and the scrotum. We use ultrasound. And then next slide, what you can do is you can actually transmit a freezing gas, kind of like liquid nitrogen, towards the tip of these probes that we put into the prostate, and you create these ice balls that freeze the prostate to very, very low temperature that literally create an ice ball in the prostate and kill the prostate cancer in the area where it's located. So this picture depicts, putting the probe in wherever the cancer may be and freezing the prostate cancer and thereby killing it through cold or the red as compared to heat, which is what high intensity focused ultrasound uses. And again, this is if you're a candidate, if you have the cancer in very specific sites in only one side of the prostate, but not in both and not throughout the prostate. The last one I'd just like to show you a quick picture of is this what's called electroporation or IRE or nanoknife. And this depicts where you can, again, through the perineum, you can put these probes, electrical probes surrounding the periphery of the cancer. And then you can literally, attach electrical currents to these probes that surround the cancer. And you can basically denature or disrupt the membranes that keep the cells intact. You disrupt the membrane and all the contents of the cells basically wash away and kill the cancer that way. So this is another new method called electroporation or nanoknife. And again, these are I would say, the three most common methods that we have for focal therapy. And again, you may be a candidate. And again, not everybody's a candidate, but if you are, we would let you know. So next slide. So I just wanted to basically give you a brief overview about risk factors for prostate cancer, diagnosing prostate cancer, side effects of prostate cancer, and newer side effects of prostate cancer. And I'm happy to answer questions over the next half hour for you. So thank you for your attention.
Okay, thank you, Dr. Kleer. So we have a few questions to get started. If you have a question and you haven't yet asked the question, you can drop it into the Q&A feature. Again, that's going to be, I think, at the bottom of your screen. Look for the two speech bubbles with the letters Q and A. Okay, so we'll get started here with the first question. Explain the Gleason score and the association with risk assessment.
Yes, excellent question. And I didn't have a chance to get into that, but Gleason score refers to the aggressiveness of the cancer. Gleason can be a little confusing because they take the two higher grades, or the two more common grades throughout the cancer, and they add them up to give you the Gleason score. So they're graded on a scale of 1 to 5, and then you get a score potentially of, you would think it's 2 to 10 because you're going from 1 to 5, but the least aggressive type of prostate cancer is a Gleason 3, and it's difficult to comprehend. So the least aggressive type of prostate cancer you can have is a Gleason 6, or 3 plus 3 equals 6, and the most aggressive is a 5 plus 5 equals 10. So it generally ranges from 6 to 10, and generally the lower the Gleason score, or the closer you get to 6, it tends to be a slower type of prostate, slower growing type of prostate cancer. And the more aggressive cancers tend to be Gleason 8, 9, and 10. What we've done now, if we've changed that to group grade. So group grade 1 is similar to a Gleason 6. Group grade 2 is a 3+4, Gleason 3+4. Group grade 3 is a Gleason 4+3. Group grade 4 is a Gleason 4+4. And a group grade 5 is a Gleason 4+5 or 5+5. So basically, the higher the Gleason, the more aggressive the cancer, and the more aggressive we're going to recommend treatment. The lower the Gleason score, or a Gleason, say, 6, that's the type of cancer that we would often recommend active surveillance or monitoring it, because those tend to be slow growing types of prostate cancers that you often may die with rather than die from, but they can grow. So we will continue to monitor those cancers using PSAs and MRIs.
Okay.
Next question.
Sure. So it looks like our next question, this person just had a biopsy done and had negative results. So we're happy to hear that. However, he says the biopsy was very uncomfortable. When they've had colonoscopies in the past, I was able to be put into twilight, so to speak, to make things easier. Can this be done for a future biopsy?
Absolutely. Unfortunately, often we do these biopsies in the office, and they can be very uncomfortable. So you can ask your urologist if they want to do it in the office, if you can have some type of at least oral sedation. We can prescribe you some Valium or Xanax. And for example, I do the transperineal biopsies, which can be uncomfortable for patients. So I do them actually under twilight in the operating room under sedation. It's an outpatient procedure. So I think it's something that you can ask your urologist, and they can help you in that department. But you're right, they can be uncomfortable. You have a probe sticking up your rectum, and so we can certainly make that a much more comfortable experience for you. You need to ask your urologist about that. Next question.
Okay. Post prostatectomy, erectile dysfunction, and incontinence. How long do these last?
So that it's very variable. Some men have some, for example, incontinence. Some men may have had significant incontinence before the surgery. Maybe they had an overactive bladder. Maybe they had a big prostate that affected how that bladder was working. And now all of a sudden they had a big prostate. That prostate is gone, and the bladder still thinks that it has this blockage there that it needs to push the urine through. So those men may take longer to recover their urinary function than men who had normal sized prostate. But traditionally, it can take up to a full year to regain your urinary control. Generally, after a year, it's not going to get much better. During that first year, you can talk to your urologist about doing what are called Kegel exercises to help you strengthen your pelvic muscles or your sphincter muscles. You can ask to do physical therapy, just like you can do physical therapy to strengthen, say, if you had a knee surgery or shoulder surgery, you can actually have physical therapy. And through Trinity, we have Probability. But physical therapists do help patients doing pelvic floor exercises that can strengthen your urinary sphincter. So ask your urologist about what they can do to help you increase the rate of recovery for that. So that can take a full year. Erectile dysfunction, that a lot depends on how good the erections were before surgery. Was your surgeon able to preserve the nerves that help you with erection? Sometimes if a cancer was large on a very large cancer, your urologist may not have been able to preserve the nerves. Maybe they saved it on one side and not the other. And those are questions you can ask your urologist. But if they were able to save the nerves, it can take up to 2 years for erections to come back. What we do to help that along is we start patients on daily Viagra or Cialis. You can use ways of improving blood flow to the penis, such as vacuum devices, penile injections, and so forth. So there's a lot of things that we can do to increase the recovery process, or help the recovery process for post-prostatectomy erectile dysfunction. But again, erections can take 2 years. Urinary control can take 1 year. And those are issues that you can discuss with your urologist who did your surgery. Next question, please.
Okay. So there are a couple questions about food. So the first one is it better to cook tomatoes in order to get those lycopenes?
I don't think it. I think you can get them either through cooking or just raw tomatoes, and I think it's not just tomatoes. That's not. I mean, tomatoes are good for you, antioxidants. So eating, just a healthy diet. I think it's more important than just tomatoes. So just eat a lot of fruits and vegetables, and avoid fried foods, and that's what you want. But tomatoes are very good. You may eat extra tomatoes, but either eating them raw or cooked, you can go either way. But the main point is eat healthy and avoid fried foods. Eat healthy and exercise. That's the way that you're going to get maximum benefit in terms of lifestyle in lowering the risk of prostate cancer. And if you do have prostate cancer, maximizing your body's ability to fight the cancer.
Now we have
Next.
our
Uh-huh.
friends in lifestyle medicine talk about a plant-based diet.
Yeah.
So is that something that you would recommend in this case?
I don't think you can go wrong with that. I'm not a vegetarian, but I know there's a lot of benefits to plant-based diet. I think it's okay to eat some protein in terms of chicken, fish, lean meat. Uh, uh, every once in a while, I think it's okay to have meat if you like a burger or a steak. Just be careful and don't overdo it. And so I think there are benefits to eating a plant-based diet. Especially I talked about soy, and it's good, especially for prostate cancer. Just eating, just lifestyle, not only plant-based diet. I don't think you need to necessarily be a vegetarian, but just live a healthy life. I think is the main point.
Okay. And you talked about milk. Is skim milk okay to drink or should milk be
Yes.
avoided? Okay, so
No.
skim milk is okay.
Yes. Just avoid whole milk.
Okay. So you're avoiding the fat, you said, correct?
Correct. Yeah.
Okay. Um, okay. So this person is scheduled for an MRI of their prostate by their urologist. What will we learn from the MRI?
Right. So an MRI is an excellent way to check whether or not there may be areas suspicious for prostate cancer. We can examine the prostate, the digital rectal exam. We can only feel the outside of the prostate. And some men, it's hard to feel the prostate if they have a thick perineum or they have a very large prostate. You can just feel the very tip of it. So the MRI is an excellent way of seeing exactly what's going on inside the prostate, and we look for areas that may harbor prostate cancer, and we can even set different grades, what are called, or sorry, PIRAT scores, a score of 3, 4, 5. If you have a PIRATS 5 lesion, that suggests about a 75-80% chance that you may have what's called at least a group grade 2 or Gleason 3 plus 4 equals 7 prostate cancer. If you have a PIRATS 4, there's a 45% chance you could have potentially a prostate cancer that you need to treat. And a PIRATS 3, you have a 15%. So an MRI is a good way to check whether or not you're maybe harboring prostate cancer, or if you have a suspicious area, it'll tell you what are the percentages that you could have cancer, and that kind of helps the urologist decide whether or not one should proceed with a prostate biopsy. And it helps us target the biopsy, as we talked about, if we use that fusion software, so we can guide the biopsy to where that suspicious area is.
Okay. This next person is asking, they have had their PSA tested, and over the last 3 years, it's gone from 0.97 to 1.65. They're 61 years old. Is this something that they should be concerned about?
Excellent question. So basically, the answer is I would tell you no. So I didn't have a chance to talk about. There is a rate of a change. It's normal for the PSA to change by around 0.5 units per year, and in older men even 0.75 units per year, because the prostate will start to enlarge as one gets older. So so I would tell you that your PSA is still low. And I think continuing to get it checked on a yearly basis is appropriate, based on the change that you described. So I would reassure you that continue to get it checked once a year. If your PSA all of a sudden changes from, say, 1.5 to 2.5, then that would be a more significant change. And then in that case, I would maybe check it again 3 to 4 months later. But I would reassure you that based on what you described, so a normal rate of change of PSA is about 0.5 in a man in their 60s, 0.75 in a man in their 70s. So good question. Next
And
question, please.
you mentioned in your talk, you said that there are primary care physicians who are no longer testing PSA. Is that something you can request if you are seeing your primary care physician for your annual exam?
Absolutely, you should request it. And unfortunately, there's been a lot of misinformation about PSA in that it's inaccurate. It puts men through unnecessary biopsies, which can cause bad side effects and infections. I talked about that. Now we're much better at lowering the risk of infections through the transperineal approach. We're absolutely also much better in determining who should get a biopsy. And, prostate cancer many men die with prostate cancer, then die from prostate cancer. But as I mentioned, prostate cancer is the #2 killing cancer in men behind lung cancer. So it's not something that you want to just hope you don't have. So you absolutely have the right to demand your primary care doctor that you want your PSA checked, and they should be offering it as well. And if it's abnormal, then have a request to see a urologist, or ask your primary care to contact a urologist for an opinion. And if it's abnormal, have them repeat it. Make sure you're not sexually active within 3 days of having a PSA done, because it can falsely elevate it. But just like you have your cholesterol checked, your sugar checked, have your blood count checked, you should definitely get a PSA check. At least, if you're in your 50s, or if you have a family history of it, or you're an African American male in your 40s.
Okay. So it looks like this person has a low PSA and a small prostate. However, they have to urinate frequently during the night. Is that generally an enlarged prostate the culprit?
So that's a good question. And so that, this talk was meant more about prostate cancer, but I'm sure that that issue is common amongst many men that are listening to this talk. So basically, so just because you have a large prostate doesn't necessarily mean that you're going to have urinary difficulties, because the prostate is actually a muscular organ. So if you have active muscle cells in your prostate, you can actually have a small prostate and have a lot of urinary issues. If you have a muscle cells in your prostate that are squeezing tight, that restrict the flow of urine through your urethra. So that's why there are medications that relax those smooth muscle cells in the prostate. You may have heard of a medication called Flomax, or Temps, or we also known as Tamsulosin, or Cardura, or Alfuzosin, or Uroxetrol, for example. So having a small prostate does not necessarily mean that you will not have urination problems. Now, getting up at night to urinate may not be due to an enlarged prostate. Many women get up at night to urinate, and obviously they don't have a prostate. So getting up at night to urinate can be for many reasons. One can be snoring. If you snore, that can make you pee more frequently at night. If your legs swell up during the day, that extra fluid, you get rid of it at night, and that can make you excrete urine at night. If you drink maybe a wine or a beer at night, that will make you pee at night. If you drink a lot of coffee or caffeine, or a lot of cola during the day, or Mountain Dew, that will also make you pee at night. So getting up at night to urinate may be completely irrespective of the prostate. And that's a whole different topic that we were not focusing today, but happy to discuss in the office, or you need to discuss that with your primary care doctor. Next question.
Okay. Is there a method for reducing the size of an enlarged prostate?
Yes, so one can reduce the size of the prostate. Now, just because you have a large prostate, again, that's not a problem. I mean, I see many men in the office who have large prostates, who may have a high PSA, but you ask them, are you urinating fine? And they say, yeah. Why? What problem should I have? And I ask them, well, are you having difficulty emptying your bladder? Are you peeing frequently? They say, no, I'm not having any problems. So that's an example of someone that may have a large prostate and it's not causing a problem. So if that's the case, there's absolutely no reason to take a medication to make your prostate smaller. On the other hand, if you're having a lot of urination issues and you are having and you do have an enlarged prostate, there are medications that reduce the size of the prostate. The main one is called finasteride or Proscar, and that's been around for a long time. It's a good medication. It can reduce the size of the prostate by about 25%. Yeah, and it can take 6 months to fully work, although it will start to work after after a month. And the longer you take it, the better it works. The thing to know about that medication is that it will change your PSA. So after you've been on it for about 6 months, your PSA will decrease by about 50%. So say you're on this medication for finasteride or Proscar, and your PSA is 2, then you need to multiply it by 2. It's actually 4 because it reduces the size of the prostate. So be aware of that. The other thing about finasteride is that it does reduce the risk of prostate cancer by about 25%. So it may have some protective effect in your risk of getting prostate cancer. It can, however, have 5% of the time, it can have sexual side effects and can cause breast tenderness, breast enlargement, 5% of the time, but that does go away if that happens to you and you stop the medication. So it can have those side effects, but they do go away if you stop the medication. Interestingly, finasteride at 1 milligram a day is what's in the medication Propecia, which is a medication that's used to help men grow hair. So Propecia 1 milligram is the same as finasteride at 1 milligram. And if you go up to 5 milligrams, Propecia becomes finasteride or Proscar. Next question.
Okay. So if prostate cancer is to spread, is it most likely to spread to certain organs or bone, bladder cancer? Is there kind of a next step after prostate cancer that you would expect?
Yeah, good question. So we talked about that early prostate cancer has no symptoms. And so you don't want to have symptoms of prostate cancer, which is how you're diagnosed with prostate cancer, because by then, basically, you're not curable, although certainly it can be controlled and you can still live for many, many years, especially with the latest advances in different types of prostate cancer medication. So typically, prostate cancer likes to spread to the lymph nodes and to bones. So before the era of PSA screening, many men presented with back pain or bone fractures because they had metastatic prostate cancer. So that is a common area of spread. Is the bone. It can also spread to lymph nodes and cause blockage of urinary flow. As it grows, it can obstruct the bladder from draining, and it can cause blood in the urine. It's very rare that that's how prostate cancer presents nowadays, but by far the most common organ where prostate presents to is the bone. That's where it likes to spread. I didn't talk about it, and we have an excellent new method now that we have of checking for spread of prostate cancer, and that's called a PSMA scan. It's a PET scan, which combines a CAT scan with nuclear medicine. PSMA scan. Not everybody needs a PSMA scan, but if you have an aggressive type of prostate cancer, and by that I mean a Gleason 8 or higher, or you have the group grade 4 or 5, or you have prostate cancer that looks like it may be outside of the confines of the prostate on the MRI, combined with a high PSA, we will often get this PSMA scan, which is an excellent way of checking whether or not a very modern way, the latest way that we have of checking whether or not prostate cancer has gone outside of the prostate or into the bones or other lymph nodes or other organs in the body. Next question.
Okay. Is there a surgery where you remove the whole prostate?
So that surgery is the radical prostatectomy, and that's the traditional surgery that we use for prostate cancer. We're we've become much better at removing the prostate and minimizing the side effects. If you have someone that's going to remove the prostate, you may want to check their experience in removing the prostate. Now we use the Da Vinci robot, which allows for much excellent visualization, better than the open technique, although it's very surgeon dependent in terms of how you're going to recover from the surgery. But even in the best of hands, there are the risks of having sexual dysfunction and urinary leakage. And that's why many men have hesitated to have the cancer even checked for or treated. And as I talked about in the talk, some men may be candidates for alternative management of the cancer with focal therapy, where you avoid those traditional side effects of the cancer in terms of treating just the cancer and avoiding the nerves and the sphincter muscle that can result in those very unwanted, untoward side effects that men want to avoid.
And can you be prescribed hormone therapy once a
So
prostate?
yes,
Okay.
yeah, hormone therapy is an important method of treating prostate cancer. Hormone therapy will control the cancer for many, many years. And that's how in the older days, that was the only treatment for prostate cancer. It actually led to the Nobel Prize in medicine when it was discovered that if you shut off the testosterone, that will cause the prostate cancer to regress. But it does have side effects, especially for younger men or men who are sexually active, because it lowers your testosterone, it lowers your sexual drive. It can cause erectile dysfunction. It does cause it can cause sweats and sweat chills and so forth. It can have untoward side effects. So we don't usually use hormone therapy unless the cancer is metastatic. But yes, it is a way of treating prostate cancer, and it's also often used in conjunction with radiation therapy because often it can make the radiation more effective. So it can temporarily be used as an adjunct to radiation therapy.
And
Next question.
Dr. Kleer, does the hormone therapy help in the recovery of like a prostate removal? Does it help in kind of recovering from some of those symptoms?
No, it does not. Now,
Okay.
one point to make is that if you're on hormone therapy for many, many years, the cancer can become what we call hormone resistant. So in other words, it gets used to not having testosterone around. So at that point, it becomes what we call hormone resistant, in which case, even though the having hormone therapy still helps, it's not as effective because some cell lines become hormone resistant and you start to require other methods, chemotherapy, in conjunction with the hormone. So we often use in what's called intermittent hormonal therapy to allow the cancer not to kind of lower the rate in which the cancer can become hormone resistant.
Okay, sounds interesting.
Next
Like
question.
similar to antibiotics.
Yeah, correct.
Okay.
Yeah.
Do erectile dysfunction medications affect the prostate? So this is if you're taking these medications prior to having a cancer diagnosis.
No, erectile medications have absolutely no effect on erectile function, and vice versa. Generally, prostate cancer, unless it's widely spread, does not cause erectile dysfunction. So erectile dysfunction is generally not a traditional effect of having prostate cancer unless it's treated. But that's not typically how prostate cancer presents as erectile dysfunction. Erectile dysfunction tends to be more caused from either low testosterone or from having high cholesterol, high triglycerides. Just some men may have heart attacks or strokes or having high cholesterol levels. That's often what causes erectile dysfunction.
Okay, and that's a symptom that you could help treat in your office as well.
Oh, absolutely. We see a lot of men with erectile dysfunction. It's a very common reason why we see patients.
Okay. I'll just ask a couple more questions
Sure.
here.
Yeah, we can keep going.
Okay. Are there any supplements that you would recommend to help with prostate problems?
I'm asked that a lot. I would tell you that, I'm not opposed to supplements. They're not very regulated. So you may think that you're taking, so some supplements like saw palmetto, for example. A lot of men take saw palmetto, which can is supposed to lower or decrease the size of the prostate. I would tell you that more important, I have some men who eat a lot of fried foods and they're taking prostate supplement because they think that's going to help them. I would tell you the most important thing that you can do for prostate health is, as I mentioned, is to eat a healthy diet, avoid fried foods, eat a lot of fruits, vegetables, tomatoes, soy, low fat, and exercise and keep your weight under control. That's by far much more important than taking supplements. It's your overall lifestyle. Just because you go to the health food store, if you're not making an effort to have a healthy lifestyle, that's not helping you at all, and you may be hurting yourself. And it may be money that you could use in maybe taking exercise or a fitness program that you could be in.
Okay. This person has a colonoscopy coming up, and they are wondering if they can ask to have their prostate checked. And if so, what exactly do they say?
Absolutely. I mean, that part of it, when a gastroenterologist does a colonoscopy, they routinely will do a rectal exam. So you can ask them, can you tell me what your rectal exam showed? I like I said, I've had a lot of patients refer to me when the gastroenterologist did a rectal exam at the time of the colonoscopy and they felt a nodule there, or they felt some abnormality that concerned the gastroenterologist, so they referred the patient to the urologist. So you can ask the gastroenterologist, can you tell me what you find when you do the rectal exam? Because I'm interested in knowing, what my prostate felt like, and please let me know if you find anything suspicious.
Okay. Is coffee traditionally good or bad for prostate health?
So I would tell you that coffee does not affect prostate health, in that what coffee does is that it has a couple effects. It tends to tighten the prostate. So, and it also can irritate the lining of the bladder. So when you drink a lot of coffee, it will make you urinate more frequently. It may slow your stream, which if you don't have a large prostate or a prostate that doesn't have a lot of these muscle cells, as I talked about, it may not affect you very much. But as one gets older, it may cause you to urinate more frequently, more urgently, even have accidents. So often when I see men who have urination issues, the first question I ask them is, how much caffeine are you drinking, either from coffee, cola, or tea? So, but otherwise it doesn't cause any harm to the prostate. It causes more urinary issues to the prostate.
Okay. And then I'll ask one final question here. Would beginning pelvic floor exercises before surgery be helpful in preventing urinary incontinence?
That's a good question. I personally don't think it'll make a big difference. I would say you can ask your urologist about doing Kegel exercises, but I personally don't think it makes a big difference. I would say many men don't have a lot of urinary problems, and it does, as I said, get better on its own, especially within the first 3 months. But if it is a problem, then you can request to see a physical therapist and start exercises at that point in time. But I would tell you, by the time you're diagnosed with prostate cancer, I don't, and by the time you get potentially a surgery, I don't think doing those, unless, I wouldn't pay to have physical therapy. You may start doing some Kegel exercises, but I really don't think it's going to make a big impact initially in your recovery process.
Okay, but maybe something you could add to your own routine if you have a daily or a weekly exercise routine that you're going through.
Yeah, sure. You can do that.
Okay. All right, we made it through, I think, pretty much all of the questions. Thank you so much, Dr. Kleer, for taking the time to present this evening. This was our first male kind of oriented presentation, and I'm so grateful that you were able to present this important topic to so many of our patients out there. So if you would like to schedule an appointment with Dr. Kleer or one of his colleagues, you will be able to do that. The contact number is on the screen currently, but you will also receive the information in an email in the next few days, along with a recording of this presentation. So you're welcome to rewatch any part or all of it if you'd like a second look or listen. And I think Dr. Kleer, what I think an important takeaway for me is to make sure that you're advocating for yourself. If you would like to have certain things included in your blood work, or you'd like to speak to your urologist, that's something that you can voice for yourself during your annual exams, right?
Absolutely. It's important that you advocate, for your getting checked for prostate cancer. Unfortunately, a lot of primary care physicians don't check it, and make sure you ask to get your PSA checked. Like I said, it's not a perfect test, but it's the best tumor marker in biology. It's not perfect, but it's very good. We understand it much better than we used to, and it can, potentially save your life. So make sure you get it checked.